So today, what we wanted to do is basically give you an introduction to what vestibular rehabilitation is and how it can be beneficial. And so really I had three main objectives I'd like to cover today, and that's and at the end we can ask a lot of questions and get as many answered as possible. But the first objective is identify the components that make up the vestibular system. There's what's called a peripheral and a central. Almost like an outside and an inside. And then we want to identify many of the typical types of testing used for vestibular rehab, both medically and in the therapy office, as well as identify the basic goals and principles of what treatment of vestibular disorders is all about. And how common is vestibular problems? Very common. As a matter of fact, it is second to back pain with balance-related falls and vestibular issues. Vestibular disorders occur frequently. They can affect people of all ages. So we see this in young folks as well as all the way through up into our older years. The cost exceeds well over $1 billion per year. And according to the National Institutes of Health, 40 to 50% of people over the age of 40 will experience some sort of dizziness or balance problems at some point in their life. So 1 of every 2 people. So it's certainly a big problem. And don't get hung up on this. There's a lot of fancy names that make us sound smart. We're going to keep it pretty simple here. But the vestibular system, as I've said, is made up of a peripheral area and a central area. When we say peripheral, we mean the inner ear. So within the inner ear here, there's these 3 semicircular canals that help orient us for balance. Okay? Those canals help give signals to the brain that tell us how to, I'm moving my head up and to the left 40 degrees. And so then the brain sends a signal to the eyes to adjust them and a signal to the muscles to react accordingly. Here's a bigger picture of that. And you have certain vestibular problems that have to do with this area here, the semicircular canals in the inner ear. Now, they're behind the tympanic membrane, so you can't see into those, but they're in behind the tympanic membrane, the ear or the eardrum, as you see here. And then the other part of the vestibular system is what I referred to as the central portion. And so that is actually the portion that has to do with the inside the brain itself, the cerebellum. And you can have different vestibular disorders that affect that portion as well. So for example, there's a condition called BPPV, or benign proximal positional vertigo. Again, fancy names to make us sound smart. Don't get hung up on that. But that is where you can either have degeneration of these little otoconia or crystals that are normally within the semicircular canals fall in and cause an issue in the inner ear, or you can have a head trauma that causes it. We see young athletes in concussions, or folks shoveling their driveways up north in the winter and knocking them loose. And we would treat then this area. Or you can have an issue centrally in the brain itself with a stroke, or you could have various types of viruses that attack this portion here that cause very different vestibular problems. And how you treat those are much different. So basically, everything works in conjunction here. We have 3 systems for balance. We have our eyes that tell us where we are relative to the environment. We have what's called proprioception, another fancy name, but we have little receptors, mechanoreceptors it's called, in all of our joints. So that's how you can feel you're on a hard surface versus grass. Okay? And that's constantly giving your brain feedback on what your position is. And then we have the vestibular system that tells you, I'm turning my head up and to the right 70 degrees. Now what happens is we can have a problem in any one of those 3 systems. Then the other 2 systems have to compensate in order for you not to have a balance problem. So as we get older and we develop cataracts or we have macular degeneration, our vision isn't able to help us like it used to, so we have to compensate with our proprioception, with our vestibular system. A lot of times folks are just visually dependent in nature, so as our vision goes, we'll start to see some balance issues. And we can improve the vestibular system to help compensate for that and avoid falls. So normally, how the vestibular system functions, like I said, don't worry about these fancy names, but the inner ear and the brain get signals that adjust the eyes and the muscles of the body accordingly. So we call the eye information that it gets the vestibular ocular reflex. It's basically a reflex. And the muscles of the body that are the writing reactions, the vestibular spinal reflex. Okay? So at its most basic level, what abnormal functioning looks like. So when your vestibular system's not working correctly, the brain's basically either getting mixed signals from the right and left side, okay? Or it's getting no information from one side, or it's having difficulty being able to process that information centrally at the brain. One of those problems will lead to abnormal functioning. Let me give some examples while I think of it. So if it's not so much anymore, we've become wise to it and gotten a lot better, but years ago, if we had a total knee and we had an infection in that knee, you might hit it with a series of really high-powered IV antibiotics. And that could cause what's called ototoxicity, where it actually poisons the inner ear, and then you're not getting a signal from one side, and suddenly you have a vestibular issue. Like I said, we've gotten a lot better at recognizing those things, and that's not as common anymore. But that's an example of what can happen. So symptoms of vestibular problems. Whoops, happy on the trigger here. This one here is oscillopsia, which is another fancy word again for jumpy vision. So just jumpy vision, kind of like my hand is with this light here. Sorry about that. Diplopia, so that's double vision. Night blindness, reading difficulty, poor depth perception. Having fluctuations or difficulty hearing, or what's called tinnitus, like the noise you're hearing. Dizziness and vertigo. Let me separate those two really quickly because sometimes they're used interchangeably. Vertigo is actually a spinning of the environment around you. So the environment appears to be moving around you. Dizziness is more of, it just doesn't feel right. I kind of feel a little off. But the environment's not necessarily moving around you. Fullness in the ear, poor memory. Now, just because you have one or a few of these doesn't mean you have vestibular problems. I have poor memory already, unfortunately, but supposedly I don't have any vestibular issues. Difficulty with coordination, fatigue. When you have a vestibular issue, it's like you ran a marathon with your mind. It's like you just sat down and took an 8-hour test. Folks with vestibular problems you'll see it in their face. It's very fatiguing. Just wears you out because the mind is constantly trying to figure out how to keep itself upright, and therefore you'll have headaches, and some of that can lead to obviously depression, unsteadiness. So what is vestibular rehabilitation? How can we help with this? Certain things physical therapy can't necessarily help with, but many of these problems we can. And what vestibular rehabilitation is, it's an exercise-based approach designed to do really these three things. Increase balance function. I talked a little bit about the three systems and how we can compensate and use strategies to beef up the other systems so that your overall balance is still good, even if you have one system not working perfectly. We use a lot of different strategies to decrease dizziness and increase general activity levels. Okay, that's at its most basic. That's what we're doing. We're trying to minimize folks' chance of falling, get rid of their dizziness or vertigo as much as we can, and generally get them back to the things that they'd like to do. What we try and do through many of these things is promote central nervous system compensation. So if you had an issue, say my ototoxicity example, where the inner ear was sort of poisoned and it's just not working anymore, there's no way to bring that back if that happened. So what we would do is we would use a lot of strategies to help the central nervous system figure out ways around that obstacle. We'd compensate, figure out, little shortcuts around that. So who might benefit from vestibular rehabilitation? Well, obviously, like I said, not all patients who have inner ear issues or central issues need this. But in general, patients who do not demonstrate a spontaneous resolution of symptoms. So if you have your symptoms just go away and you're good, obviously you're not going to benefit probably from vestibular rehab. Patients with acute or abrupt loss of function. So those folks usually need some medical management first. Patients who have undergone medical management using medications with little to no success. Patients who have vestibular problems that are not fluctuating in nature. So an example of that is Meniere's disease. Meniere's disease is a situation in which we have a certain mix of sodium and potassium levels in the fluids in the body, and the inner ear is separate from the rest of the body. In Meniere's disease, it becomes one and the same. You get a hole and you get passage of the fluid. And so in Meniere's disease, really the only benefit we can help from a physical therapy standpoint is a session or two on counseling of how to keep your sodium intake consistent and not fluctuate that, how to keep your salt intake down and those kinds of things, because fluctuations in that now suddenly affect the inner ear. But many vestibular problems, it's there and it's not necessarily fluctuating. Oh, it's fine, now it's bad. No, it's fine, now it's bad. Most of the time it's some degree of debilitation, and that would be an indication for somebody who could benefit. Or patients who have just had surgery. Those patients obviously can benefit as well. Diagnoses that you may hear from a physician: distorted function, which is BPPV, I alluded to that, benign proximal positional vertigo. A lot of docs will refer to that as you have rocks in your head. And really it's these little calcium carbonate crystals that are there naturally, but they get misplaced. It's actually a very easy fix for folks. It's actually one that's fun to treat because you can improve someone's quality of life like just really quickly. Fluctuating problems, in this I gave this example, Meniere's, or a perilimb fistula it's called, and so they're on bed rest due to that. Or central problems, remember in the brain that I talked about, so stroke, head trauma, problems at the cerebellum. Decreased sensitivity, so a postneuronitis. So all that means is itis is just inflammation. You got bursitis, tendonitis, you got all these different, so it's just inflammation of the various areas. And so this is inflammation of the neuron. Ototoxicity, talked about that. Head trauma or concussion, a lot of times we'll see it. Age-related degeneration, vascular occlusions, and then there's post-surgical patients like sometimes if it's severe enough they'll go in there and surgically sever the 8th cranial nerve. Common testing you'll see diagnostically is a electronystagmography, which is basically ENG, and so that's different from EMG. It looks at muscle activity. This is looking at the activity of your eyes. Okay, and real quick on that. So when I look up and to the left, 40 degrees, I should get that vestibular ocular reflex where my brain then wants to adjust my eyes. Okay. Well, when I do that, if one side's saying, yeah, you moved up to 70 degrees to the left, and I adjust my eyes, and the other side is getting information saying, no, you didn't move because it's not working properly, then the eyes will be caught back and forth between that fight, between that argument. Move back, and that's where you get the eyes moving, what's called nystagmus, is what they call it, okay? And you can have that with many different things, but basically ENG there is measuring that. Hearing tests, also called, they'll do what's not. What does an evaluation look like within a physical therapy office? Well, we would do all the normal things that we would do for any orthopedic issue. We'd first of all, we learn the most by talking to you. You know your body better than anybody. Then we go through and do our neuromuscular assessment, look at our strength, range of motion. How is the myotomes, what are the nerves doing in there? Sensation-wise, does somebody have a issue sensation in the bottom of their foot? They have a history of diabetes and their sensation isn't very good. Now maybe their proprioception's not there. So we know that their balance is going to be more dependent on vestibular system and vision. We look at cerebellar coordination to see if we can pick up on any underlying issues there. We're going to look at some postural assessment stuff. And then some different things we do for the vestibulars. We're going to look at visual acuity. So we're going to want to see how people's vision are doing, especially with movement. There we go. Eye-head movement coordination type activities. We're going to look at what's called the CAT-SIB, or sensory integration and balance. And that's basically putting you on foam so you're not on a firm surface and seeing what happens, taking away your vision, those kind of things, and see what road that leads down. Obviously looking at a gait assessment. Do we have any vertigo? We're going to look at a lot of the cranial nerves to see if we can pick up on any issues there, more than we would just with general orthopedic issues. And then we're going to be doing some sort of measurement outcome to see, hey, how much of a positive improvement are we making for these folks? We want to see that we're making a difference. More along the lines of 2 to 3 times a week for 6 to 8 weeks, because we have to do a lot of central nervous system compensation. So it depends on, I always hate giving the answer depends, but in this case it depends. How much, where the area is affected, and to what degree. And then we really try and work closely with the doctors to take people off their vestibular suppressants. So off of meclizine, off of antivert, because those things are going to suppress your vestibular system. And so we don't know if we're seeing an issue there or not, because it's all suppressed by the medication, and we don't know if we're helping it. So we'll take you off of that, work with the doctor on that to make sure we're getting you better and that you don't need any medications. So just to reiterate this, the major goals of vestibular rehabilitation therapy, it's to facilitate central nervous system compensation, so to habituate your central nervous system. So, hey, here's a problem. The way you solved it before, we have to figure out a new way of solving it now. And so we help it do that. We prevent abnormal compensation. So a lot of times I'll get people, we call it movement on block. So people will stop moving their head altogether, and pretty soon now they're just moving as a unit. They're getting abnormal compensations, doing whatever they can to try not to get the symptoms, which is understandable, human nature, and so we try to help prevent that by getting them better with the other stuff. We reduce the vertigo with the habituation exercises. We do a lot of work with the vestibular ocular reflex and improve that. So it should be a 1-to-1. I move my head, for example, to the left 30 degrees. My eye should move to the right 30 degrees in order to keep an image stable on my retina. If I move my head left 30 degrees and my eyes only go 20 degrees to the right, that image isn't stable and I have a higher chance of falling. So we do a lot of work in therapy to get that back to a 1-to-1 relationship, 30 and 30. And obviously reducing imbalance and ataxia, another fancy word there. Really trying to impress you guys, I guess, with some of these. Now, but another fancy word for just saying, you have a problem walking. So we do a lot of balance work around that. Again, trying to hit all three systems, make them the best they can be. And then treating any secondary musculoskeletal issues. So that example I gave where somebody's doing this, if they've done that for a long time, you can bet I'm going to have to get up into the musculature and help get that right again. Their levator scapulae or their upper trap, some muscles in there are going to be very tight and just adapted to that shortened position. And I'm going to have to help get that back to its normal length tension relationship so they have the ability to move their cervical spine through its range of motion. We got to reduce problems with gaze stabilization and improve physical conditioning just so they have the long-term retention of those new skills that they've built up in their central nervous system. So that is a very short and sweet overview of what vestibular rehabilitation therapy is. But I wanted to leave lots of time for questions and